So case one continued here. Germline molecular testing was BRCA wild type, and the patient was homologous recombination deficient. My assumption is based off the Myriad test, high-grade epithelial ovarian cancer involving omentum, both ovaries, and had metastatic disease to the lymph nodes. So what are the key, what are the current treatments available for this patient for primary upfront therapy? To me, I think we can get into a nice discussion for this. This patient's optimally debulked to microscopic disease. She's young, she's fit, and she's HRD positive or homologous recombination deficient. So, to me, I think a platinum-based chemotherapy regimen is important. I still do try to do IP chemotherapy for the young patients that desire to be treated as aggressively as possible. I do think that there's a role for IP chemotherapy in this patient population. It does have increased side effects with abdominal pain, nausea, vomiting, and I do think that the IP cisplatin at times does have some chronic renal, I do see some changes with baseline creatinine. So to me, this patient will get some type of platinum-based chemotherapy. I do like IV chemotherapy for them, but also think that she could be treated with platinum-based carboplatin and paclitaxel. So I'm curious to see what my other colleagues would think about this.
Chad, what would you do?
So this patient is HRD positive, BRCA wild type, right?
Correct.
So I think per the NCCN guidelines, the preferred regimens would either be the Q3 week carbotaxol regimen, or perhaps carbotaxol Bev plus Bev and with Bev maintenance, and then specifically in this case with the optimally debulked patient, then the IVIP certainly comes back into play. To be honest with you, I've sort of waffled on where I've stood on IVIP. I think a lot of our specialty has, so I can't say that I'm consistent in what I do at this time with these patients. And I think some of it depends on performance status and sort of intangible things that go along with that. I'm probably doing more Q3 week at this point than IVIP, but either one are certainly reasonable options.
I would agree with Tom how we do our testing. We've generally done germline testing first and then done kind of a reflex to somatic and HRD if the germline's negative. For this patient, the presence of HRD positive disease is going to sway me and might sway me more to just chemo only versus doing, say, chemotherapy with bevacizumab or whatnot, because I know this patient has been optimally debulked and I'm going to be able to get her onto subsequent PARP inhibitor maintenance. So my goal is to, get a good response to therapy and then be able to transition her to maintenance. I definitely have used less IP therapy since the results of, 262 and Icon 8, and all of these. I was doing a ton of dose dense. I was doing IP, and then everything seemed to be a wash, and it seemed that chemotherapy, just every 3 weeks was just fine. So I definitely think my practice has changed to some degree. But with that being said, in a young woman that I've gotten down to no gross residual disease, I do talk to them about intraperitoneal therapy, and to your point, the intangibles. Some of it is, where are they located? Can they get IP therapy where they are? Is it safe? And if it is, then I do encourage them to consider that. I think for, other, characteristics that help me make a decision, overall, just the performance status of the patient, do they have to work? What are their other responsibilities? I mean, all those things have to influence it.
I think in contrast to your testing scheme, we are sending our patients pretty early after their diagnosis. One of their initial visits to our genetic counselor, like you are, but almost in parallel, we're then ordering somatic testing of some sort on those patients. Some patients get lost between our office and trying to get to the genetic counselor, so I don't get that information back quickly, and they will drag their feet, or life will intervene, or overwhelmed with everything. And so I just find it a lot more helpful if I get the ball rolling, which we can do on our end for the somatic testing. That should capture about 95% of folks that will have a germline mutation as well. So it's sort of a catch-all if patients don't move forward with getting their germline testing done.
Yeah, I think germline testing is important for two reasons. One, now obviously for treatment, but also cascade testing. I really do think an ounce of prevention is better than a pound of cure. So I do like the panel test because that does identify some of the low penetrance genes that may have an impact. And, you know, I've been doing this long enough that I've actually treated patients and now have seen family members and done risk reducing surgery. So that actually makes me feel good that people are following with the geneticists and they are talking with their families and getting that done. And I completely agree with Shannon in that I like using IVIP chemotherapy, but really your focus was on making sure people stay healthy enough for maintenance. Because, you know, to me, my biggest concern at times, if I harm them or make them so sick they don't want maintenance off of IVIP, it's probably more important to make sure those patients are doing well coming off their adjuvant chemotherapy to go on maintenance. So that is one concern. I would say that our utilization of IVIP chemotherapy has decreased. So very nice.
Your last question was how does this scenario influence your decision or not to add Bev to the treatment regimen? Certainly, as Shannon mentioned, the HRD aspect sways me to think more about PARP maintenance, but I really am still reserving Bev for those patients that have bulky residual disease or a lot of ascites, the ones that we really had a signal in the subgroup analysis of the phase 3 trials that may be getting more bang for the buck from the Bev maintenance.
Yeah, I agree with that. I think that my decision to use Bev is really based on those factors rather than anything else. And so for this particular patient who we've been able to get to an R0, I likely would not use it.
I'm a big bevacizumab proponent. I think that it's the volume of disease before surgery is important. So even if they get to R0, I'll still use it. And again, it's a struggle because to me, you know, it meets with the label, but you see the data and you understand the data. And so I'd have to say that's a bias where some of the science supports me not to use it, but I still, my bias has been to use it because intuitively I think it works in that patient population. So.
Well, now you have the opportunity that you can, you know, add PARP for this patient, let's say with an HRD positive tumor. You know, if you've started Bev, then you don't have to make the decision of whether or not you want to keep going with the Bev or stop it. You know, you have data to support using both.